Dear fourth year students, today we will talk about drugs for heart failure. But before we starting, we have to talk about heart failure. So heart failure is a complex, progressive disorder characterized by pumping insufficient amount of the blood to the other parts of the body. And there are a couple of symptoms that are related to heart failure, such as dyspnea, fatigue, and fluid retention. And mainly, as we see, all these symptoms are related to the impaired ability of the heart to either adequately fill or eject blood to the body. There are many underlying causes for heart failure, but mainly happens due to either atherosclerotic heart disease, myocardial infarction, hypertension, valvular heart diseases, and congenital heart diseases. With heart failure, there are a couple of compensatory mechanisms trying to increase the function of the heart. Mainly, these mechanisms include the renin-angiotensin-aldosterone system and sympathetic nervous system. However, these mechanisms are related with more deterioration to the heart function due to increasing the remodeling of cardiac tissue, losing more cardiomyocytes, hypertrophy, and fibrosis. As we said, there are a couple of classes of drugs that are used now to treat heart failure. Here, the table on the right, just to summarize all these drugs. It is not required to memorize everything in this table. But what are the goals of from using these drugs? The main goals, of course, to alleviate symptoms, to reduce the severity of the symptoms, also to inhibit the process of disease progression and improve survival. And so that there are 10 classes of the drugs that are used for these purposes. And what we are expecting from these classes, the other things. We are expecting to reduce the myocardial workload. Of course, if we are reducing the workload on the heart, we are protecting the heart from more deterioration in its function. We also expecting to reduce the extracellular fluid volume, and this is a main feature with the heart failure in order to reduce the volume that of the blood that is reached to the heart, and this is going to protect the heart from more oxygen demand and more workload. Also, we are expecting to increase or improve the contractility of the cardiac muscle to eject more blood to the heart. And also we are expecting to reduce the rate of cardiac remodeling. So this is what we are expected from the drugs that are used for heart failure. Before starting with the drugs, we have to talk about some physiological functions that are the normal physiological functions that are done by cardiomyocytes. The first one is the action potential. So cardiomyocytes are electrically excitable cells. They are generating electric potential, and this electricity generated from two main sides, the sinoarterial nodes and arterioventricular nodes. Then the action potential is transmitted from these two sides to the other part of the heart. Action potential in the heart is a little bit long action potential, and there are 5 stages here. Includes in this action potential. It is not required to memorize this figure, but just to illustrate the action potential in cardiomyocytes, because we will see there are some drugs are working on these physiological mechanisms. So here in the phase 0, it is a depolarization phase. It is characterized by the opening of the sodium channel. It is called fast channel, so there is inward movement of sodium ion inside the cells. Then after that, there is a little bit closing for this channel and activation for the potassium channel. And there is outward movement of potassium outside the cardiomyocytes. But this movement, it is it is so fast. Like this channel, it is opening and closing so fast. Then after that, we have phase two, and it is mainly controlled by the voltage sensitive calcium channel. And here there is a little bit the slowdown in the movement of potassium outside the cells, but there is inward movement of calcium ion inside the cells. Then there is in the phase three, there is a closed the channel, this voltage sensitive calcium channel is closed, and there is more movement for potassium ion outside the cells. And this is gonna to increase or change the gradients of electrolytes across the cell membrane, and this is gonna to move the cell to the phase four. And in the phase four, the cells or these cells are prepared for a new depolarization phase. Then also the other important function that is done by the cardiomyocytes is the cardiac contraction. And mainly cardiac contraction is controlled by the level of the calcium inside the cells. And let's talk about this figure. It is important to know because we will see there are a couple of drugs are working on these mechanisms. So the level of the calcium ion is controlled in the cardiomyocytes by this pathway, but it is also controlled by other pathway. But in this pathway, there is a movement for the calcium ion inside the cells through voltage-sensitive slow calcium channel. Increase the level of the calcium inside the cardiomyocytes is going to activate sarcoplasmic reticulum to release more calcium inside the cells, and this level of the calcium is going to activate myofibrils, and this is inducing contraction. It is important to notice that after this effect, the contractility effect, the excess of calcium is either restored in the sarcoplasmic reticulum again, or it is moving outside the cells through this sodium calcium exchange. But this one needs the effect of other ITPase, other channel or ITPase system. It is called the sodium potassium ITPase because this one is causing movement of the sodium ion outside the cells, entering of the calcium, and the level of the sodium here is controlling the level of the calcium. So this is how the cardiomyocytes are controlling the level of the calcium ion inside the cells. And mainly the drugs that have inotropic effect is working through these mechanisms. As we said, there are a couple of compensatory mechanisms with the heart failure trying to protect the heart from more deterioration in its function. And mainly these mechanisms are including sympathetic activity, renin-angiotensin-aldosterone system, natriuretic peptides, and myocardial hypertrophy. So when there is a heart failure, there is decrease in the cardiac output, and there is a decrease in the blood pressure. Decrease in the blood pressure is going to activate the baroreceptors, and baroreceptors will activate the sympathetic activity. Sympathetic activity increases the cardiac contractility, increases the heart rate, and is causing vasoconstriction. It is similar to what we discussed with the antihypertensive drugs. But with the time, will induce more stress to the myocardial muscles, and this means cardiac hypertrophy, as we will see then myocardial hypertrophy and more deterioration in the heart function. The other mechanism is the renin-angiotensin-aldosterone system. When there is a decrease in the renal blood flow, this is, of course, will activate the renin-angiotensin-aldosterone system to produce angiotensin 2 and aldosterone. This one is a potent vasoconstrictors, and this will try to increase induce or produce more amount of the drug to the heart. The other one, aldosterone, is trying to increase the volume of the blood in order to also reach more amount of the blood to the heart, so that the heart will eject more amount of the blood to the other part of the system of the body. However, these two mechanisms are related with more remodeling in the heart. I mean, more deterioration in the heart function, and the heart size, and the heart shape. And so these are harmful mechanisms. Then after that, we have the activation of natriuretic peptides. When there is an activation for an angiotensin aldosterone system, there is an activation for natriuretic peptides. And natriuretic peptides, the main effects are related to these peptides. They are potent vasodilators. They are potent natriuresis. So they are trying to reduce the volume of the blood and reduce the workload of the heart. And finally, we have myocardial hypertrophy, and this is, as we said, it is related to the overstretched myocardial muscles due to overactivation of the sympathetic activity. Here we have a term called decompensated heart failure, and it means that when the compensatory mechanisms fail to maintain the heart function, we have here a decompensated heart failure. Means more worsening heart failure and worsening the signs and symptoms that are associated with the heart failures. And here we have more symptoms like dyspnea, exertion, orthopnea, etc. Therapeutic strategies in heart failure, as we said, as we saw in the previous slide, there are mechanisms, and here we have to deal with these mechanisms. We have to either inhibit renin-angiotensin-aldosterone system, inhibit sympathetic activity, or enhancing the natriuretic effect in the body. Of course, inotropic agents are beneficial in the heart failure, but these are a couple of combined mechanisms. On the other hand, we have to avoid certain drugs that could deteriorate more the heart function, such as non-steroidal anti-inflammatory drugs, calcium channel blockers, anti-arrhythmic drugs. So let's start with the first system, the renin-angiotensin-aldosterone system, and starting with the angiotensin-converting enzyme inhibitors. As we saw with the angiotensin-converting enzyme inhibitors, they are working on this enzyme right here, so they are decreasing the production of angiotensin 2, as we saw with the antihypertensive drugs. So reducing the production of angiotensin 2 is related to reduce the sympathetic activity, protecting the heart. Vasodilation also is protective for the heart muscles, and reducing the retention of sodium, water in the body, decrease the volume of the blood. In addition to all these effects, there is an increase in the level of bradykinin due to inhibition of the AC enzyme. And as we discussed earlier with the antihypertensive, the bradykinin is a potent vasodilator, and this is going to decrease the both preload and afterload, and decrease the workload of in the heart, and decrease the oxygen demand. So here it is important to notice that or to mention that the afterload, it means vascular resistance, so that the heart needs to eject less amount with less force to the blood vessel arterioles. And also a preload, it means like vasodilation in the venous system, and this is going to reduce the amount of the blood that is reaching to the heart. IC inhibitors are very effective in reducing the symptoms of heart failure, and they are significantly improve the patient's survival. Therapeutic uses, as we said, that they are indicated for all stages with the heart failure. Here, we didn't discuss in detail the all stages of the heart failure. There are 4 stages from the mild to very severe heart failure, but here it is important just to notice that what classes of the drug that are working on all stages, or which stages of the heart failure. Also, the other beneficial effects for using angiotensin converting enzyme inhibitor, they are protective against the process of adverse cardiac remodeling. It means the change in the heart size, change in the heart function, change in the heart shape. A process leads to heart failure after myocardial infarction. So it is important to indicate AC inhibitors after myocardial infarction. Pharmacokinetic and adverse effects, we discussed this earlier with the antihypertensive drugs. Then the other class in this system is the angiotensin receptor blockers, and here we have drugs similar to angiotensin converting enzyme inhibitors, but they could be more powerful drugs since they are causing a complete block for angiotensin receptor, for angiotensin 2 receptors, unlike just inhibition the angiotensin converting enzyme. The other important thing, they are similar in indication, but they are different in adverse effects. So the angiotensin receptor blocker, they don't have an effect on the bradykinin levels. So there is no effect. There is no side effects such as dry cough or angioedema. There is angioedema, but it is less severe than angiotensin converting enzyme inhibitors that is induced by angiotensin enzyme inhibitor, angiotensin converting enzyme inhibitor. Sorry. Then we have with the action, as we said, similar to the angiotensin converting enzyme inhibitors, and they are working on both in preload and afterload. Pharmacokinetic and adverse effects, we discussed this earlier with the antihypertensive drugs. Aldosterone system, aldosterone receptor antagonist, as we said with the diuretics. So these drugs are blocking the aldosterone receptors, and from this figure that aldosterone is also is let's go back here. So here we have sodium and water retention, and blocking this effect. This effect is related to the renin-angiotensin aldosterone system. So by using aldosterone antagonist, we are blocking this effect. So there is no sodium and water retention and decrease the volume of the blood. We have two drugs, and they are effective in preventing salt water retention, myocardial hypertrophy, and hypokalemia. They are different in their adverse effects since they are different in their structures, a little bit difference between spironolactone and eplerenone. There is no androgenic side effect, androgen or progesterone side effects with the eplerenone, unlike spironolactone. So at the end, aldosterone antagonists are indicated for patients with symptomatic heart failure or with recent myocardial infarction, similar to what we saw in the indication of the angiotensin receptor blockers and the angiotensin converting enzyme inhibitors. Then we have beta blockers. From the beginning, like using beta blockers for patients with heart failure seems strange, since these drugs have negative inotropic activity, decrease the contractility of the the contractility of the heart. However, the clinical evidence show clearly like they are improving the systolic function, it means improving the heart function, and they are stopping the process of cardiac remodeling. And this comes to the mind from the to what we saw with the mechanism that are related to the heart failure, decrease the activity of the sympathetic system due to decrease in the blood pressure. With the first use of the beta blockers, there is maybe there is increase in the severity of the symptom, but after a while there is a very clear improving in the symptoms of heart failure. As we said, like the benefit from using beta blocker, they are prevent changes that occur because of the chronic activation of the sympathetic nervous systems. And also there is another effect. There is they block the activation of renin angiotensin system in the kidneys, and also they are preventing the deleterious effect of norepinephrine in the cardiac muscle fibers. These effects are related to more remodeling, hypertrophy, and cell death, and all these effects are blocked by using beta blockers. The main beta blockers that are used in heart failure are bisoprolol, carvedilol, and metoprolol. And this one is non-selective beta-alpha receptors, non-selective blocker, while both to the bisoprolol and metoprolol, they are selective beta-1 antagonists. Recommended for all patients with chronic stable heart failure. And they are, as we said earlier, they are approved by clinical trials in reducing the morbidity and mortality associated with the heart failure. So let's talk about pharmacokinetic. Carvedilol and metoprolol are metabolized by this cytochrome 400 to D6, 452D6. So if there is an inhibitor, this is gonna to increase the level of these two drugs and maybe induce toxicity. The other important thing about carvedilol specifically is this drug is also metabolized by glycoprotein. So also if there is an inhibitor, this will increase the level of carvedilol. And also these drugs should be avoided or used with caution with the drugs that are blockers or inhibitors for IV conduction, such as amiodarone, verapamil, and diltiazem. Diuretics. So as we discussed earlier, there are symptoms that are related to volume overload due to decrease the activity of the heart and eject a good amount of the blood. So there is an accumulation of these fluids inside the body. Accumulation of the blood, then an increase in the volume of the interstitial fluid, and even increase the volume of the blood and increase the volume of the and all these effects are causing dyspnea, exertion, or thermia. So these are symptoms. Diuretics are effective in reducing the severity of these symptoms through reducing the plasma volume, and this is will reduce the preload. So they decrease the amount of the blood that is reaching to the heart. But also they are effective in and reducing the afterload because they are also since they're reducing the plasma volume, it means there is a decrease also in the afterload. So there is in total there is decrease in the cardiac workload and decrease in the oxygen demand. The most useful class with the class of diuretics in the heart failure is the loop diuretics, since they are very strong diuretics, and at the same time even when there is renal insufficiency they are still effective. But from the clinical trial, they are not useful in improving survival, but still they are useful in improving the sign and symptoms. Then here we have a new combination of drugs, a combination between angiotensin receptor blockers and neprilysin inhibitor. Neprilysin is an enzyme responsible for the breakdown of vasoactive peptides, such as angiotensin 1, 2, and natriuretic peptide. So let's go to this figure. When there is a decrease in the cardiac output, there is an increase in the activation of renin-angiotensin system, and this increases the production of angiotensin 2. And it is harmful angiotensin 2 with the heart failure. On the other hand, as we said in the compensatory mechanism, when there is an activation for an angiotensin aldosterone system, there is an activation in natriuretic peptides, and here we have atrial natriuretic peptides and B-type natriuretic peptides. And both these two are leading to the vasodilation effect, natriuresis, and decreased cardiac remodeling, and decreased renin and aldosterone. But in the presence of neprilysin, all these effects are not seen. So by using a combination between neprilysin inhibitors and angiotensin receptor blockers, but using this inhibitor right here, it contains both these drugs. We are with the net effect vasodilation, natriuresis, decreased cardiac remodeling, decrease in the volume retention. So the main idea here, increase the activity of the natriuretic effects and at the same time blocking the harmful effect of renin-angiotensin aldosterone system. In this class, we have a combination sacubitril with the valsartan. So by using this combination, we are increasing the concentration of vasoactive peptides. This leads to natriuresis, diuresis, vasodilatation, and decrease fibrosis. And also from the effects of the angiotensin receptor blockers, we are expecting to decrease the afterload, preload, and myocardial fibrosis. Therapeutic indication: when the patients on the other drugs, they are taking either IC inhibitors, angiotensin receptor blockers, or even beta blockers, and still symptomatic, so it is very beneficial to use this class of drugs. Pharmacokinetics. With the pharmacokinetics, this drug is this combination. After taking, it is gonna to be separated or metabolized in the into two components, the same components, sacubitril alone and valsartan. Cyclopater is transformed to the active metabolite by plasma esterases, and this drug has a high volume of distribution, and it is highly bounded to the plasma protein, mainly excreted by the urine, and the half-life around 10 hours. So this drug is given twice daily. But the adverse effects is similar to the adverse effects of angiotensin converting enzyme inhibitors or angiotensin receptor blockers. However, there is a combined effects on the hypotension. So we are expecting to see more hypotensive effects as side effect with this combination due to decrease the afterload. And also due to there is no inhibition for bradykinin, so we are expecting to see angioedema in the patients. Here in this class, the hyperpolarization activated cyclic nucleotide gated channel blocker. Here we are focusing on the heart rate. As we discussed in the heart rate and the action potential, there is a channel that is called fast channel, and fast channel is responsible for inward movement of sodium ion inside the cell. By blocking this channel or slowing the movement of sodium ion through this channel by using this drug, Ivabradine, we are reducing the amount of the sodium inside the cell, and this is gonna to delay or slowing the diastolic depolarization, and diastolic depolarization in the cornerstone, or it is responsible for the heart rate. So we are reducing the heart rate by reducing the diastolic depolarization through slowing the movement of sodium ion through the fast channel by using Ivabradine. It is very clear effect, but here it is important to reduce the heart rate. We are not causing any other effects. With the action, so as we saw, the ivabradine, it is mainly effective in the SA node, and the generation in the pacemaker membrane, the generation of the electric or action potential in the cardiomyocytes. Reduction of the heart rate occurs with the reduction, without a reduction, it is very important, without reduction. So there is no effect on the contractility, there is no effect in the IV conduction, ventricular repolarization on the blood pressure, just we are reducing the heart rate in these patients. This is gonna to reduce the oxygen demands and reduce the workload on the heart. Here also, mainly it is indicated this drug for patients still symptomatic, and with the other drug they are using other drugs, but they are still symptomatic. And also there is another feature, they are with the sinus rhythm or with the heartbeat above than 70. When there is a very high heart rate, it is beneficial to this class of the drugs. With the pharmacokinetics, it is important to use this drug with meals to increase the absorption of the drug. There is a first pass metabolism for this drug through this cytochrome 453A4. So if there is an inhibitor for this system, it's gonna to increase the concentration of the drug and may cause the toxicity, which needs to reduce the dose of the drug. This drug also has a high volume of distribution with the half-life 6 hours, which means a twice daily dose it is recommended for patients. From the mechanism of action, we are expecting bradycardia as side effect. This one, and also we are expecting, as we said earlier, that this drug is effective only on the SA node. There is no effect on the AV node. So we are expecting to see arterial fibrillation. This drug is also an inhibitor for the same channel, but in the eye, causing luminous phenomena. It means that there is an enhanced brightness. So this is a side effect, and all these effects can be controlled by reducing the dose or using a titration for the dose. Then we have vasodilator. So as we said earlier, like reducing both preload and afterload, it is protective in heart failure. It means that it is reducing the workload on the heart, reducing the oxygen demands. And for these effects, we are using either nitrates, which are venodilators, they are reducing the preload, or using hydralazine, which is arterial dilator, it is reducing the afterload. So, or by using a combination of both drugs. So the patients, they are using these drugs, such as angiotensin converting enzyme inhibitors, beta blockers, or angiotensin receptor blockers, and they are symptomatic or there are contraindications for these drugs, it is beneficial to consider vasodilators. But from the pharmacology, we are expecting to see headache, dizziness, and hypertension as side effects with these drugs, and rarely hydralazine could cause drug-induced lupus. It is a kind of hypersensitivity reaction. Inotropic drugs. With the inotropic drugs, these drugs mainly affecting on the cardiac contractility. They are increasing the cardiac contractility in order to increase the ejected amount of the blood from the heart. They are working by different mechanisms, but they are still positive inotropic drugs. They are increasing, and they are mainly working through the increasing the level of calcium ion inside the cells, as we discussed earlier in the cardiac contractility. The main class on the cardiac or the main drug in this categories, as we will see later, is the digoxin. It is very important drug in all inotropic drugs, but there are other drugs and they are effective, but they are mainly indicated for inpatients. Digitalis glycosides. The most important one here is the digoxin, but there is a very important thing to notice with the digoxin that this drug has a low therapeutic index, which means there is a very small difference between therapeutic dose and the toxic dose. So the toxicity is expected even with small increase in the dose. With the mechanism of action, this drug is working by more than one mechanism. The first one through inhibition, the sodium potassium ATPase here. So it is preventing the movement of sodium outside the cells. This will increase the level of sodium inside the cells and at the same time increase the level of the calcium because there is no outward movement of the calcium outside the cells. And as we said earlier, increasing the level of the calcium, this will release calcium from the sarcoplasmic reticulum, and this causes contraction of myofibrils and increase the contractility of the myofibrils. The other important effect with digoxin increase the cardiac contractility. It is increasing the force of cardiac contractility, and returns it is back to the normal function. The digoxin, it is an inhibitor or it is an enhancer or activator for the vagal tone. And this one, it is related to reduce heart rate and reduce the myocardial oxygen demand. Digoxin as well, it is an inhibitor or it is slowing the conduction velocity in the IV node. To understand all these effects, we have to look at this figure, but this figure is not required, but is a kind of complicated figure. So let's start here from the beginning. So with the normal heart function, there is stretch myocardial, and it means increase in the stretching of the myocardial muscles, ejection more amount of the blood outside the heart. But with the time overstretching the heart of the myocardial muscles will reduce the function of the heart, and there is a movement. Here we have starting the point or the starting point of the heart failure when we are moving from point A to point B. And here in the point B, we have decompensated heart failure. It means uncontrolled symptoms with the heart failure. And the first symptom that we will see with the heart failure is the fatigue. Here there is overstretched myocardium, inadequate amount of the blood ejected from the heart, and with the time there is appearing for the symptoms of the heart failures such as fatigue. Then from the point B, there is a movement to the point C when the heart, the ventricular and diastolic pressure in the heart trying to maintain the heart function to eject more amount of the blood or outside the heart. So here we in the point C, even though the heart is trying to increase the function it is function, but here there is more deterioration in the heart function due to overstretched myocardium. So there is more appearing for the heart failure symptoms such as dyspnea in addition to the fatigue. So here we have the heart in this point. So by using drugs that are positive inotropic, increasing the contractility of the heart, we are shifting the heart from the point C, failed heart, compensated heart failure, to the point D. And here, through using a positive inotropic agents, not through just increasing the ventricular and diastolic pressure. But this one, taking the heart from this point from D to E, and D, it is close to A, it means that we are maintaining the heart function similar to the normal. So what we can say here that the digoxin through increasing the level of the calcium, it is increasing the contractility of the heart, the force of contraction, and at the same time there is an inhibition for the vagal tone, which means reduce the heart rate, and also there is a slow conduction of the slow conduction velocity or conduction velocity through the IV node, which means also reducing in the heart rate. As we said, this figure is a kind of complicated figures, and it is applicable for all kinds of the anti-heart failure drugs, but still it is explainable. The explanation for this figure is more appropriate with the digoxin. Neurohormonal inhibition, the third mechanism by which a digoxin is used for heart failure patients. For this mechanism, there is no clear mechanism like how digoxin causing neurohormonal inhibition. But with through this mechanism, digoxin inhibits sympathetic activation with the minimal effects on cardiac contractility. So here, by using low doses of digoxin inhibits sympathetic activity, and as we said that increased sympathetic activity in the heart failure, it is bad or deteriorates the heart function more and more. So by using an inhibitor for the sympathetic activity, we are protecting the heart from more deterioration in its function. But as we said, like this mechanism is still not very understandable, but it happens with the low concentration of digoxin, and this is also a benefit for digoxin because, as we said, like digoxin has a very low therapeutic index, which means there is a small difference between therapeutic and toxic doses. So with the digoxin is indicated for patient symptomatic or asymptomatic with the optimal heart failure pharmacotherapy. So patient, they are using AC blockers, angiotensin converting enzyme inhibitors, or beta blockers, but they are still symptomatic. So it is very beneficial to use a drug similar to digoxin with positive, a very clear positive inotropic effect. Pharmacokinetics. It has this drug has a large volume of distribution. It is accumulated in the muscle. So when there is an urgent need to use digoxin in patients, it is very beneficial to use loading dose in order to reach to the steady state effects, which means the highest effects with the lowest potential of adverse effects. Digoxin has a long half-life, like around 40 hours, and it is eliminated mainly by the kidney, so it is required to make dose adjustment if there is a renal dysfunction. As we said, digoxin has a very narrow therapeutic index, so there are many side effects are related to this drug, such as anorexia, nausea, vomiting, blurred vision, yellowish vision. The other side effects are related to the mechanism of this drug, such as with the digoxin, it is an inhibitor for this ATPase, and so this drug will increase the resting membrane potential, and this means that this the membrane will be more excitable and increase the potential of risk of arrhythmias. So the cardiomyocytes resting membrane potential increase, and this means it is very excitable membrane, and this means that it is very susceptible to a risk of arrhythmias. The other side effects is also related to the mechanism is the hypokalemia due to the competition between digoxin and potassium for this for the sodium potassium ATPase, and also similar to the what we saw with other drugs that such as carvedilol. Digoxin is metabolized by P-glycoprotein, so if there is an inhibitor such as clarithromycin, verapamil, this will increase the concentration of this drug. The second class in the inotropic agents is the beta adrenergic agonist. And here we have two drugs, dobutamine and dopamine. And these are increasing the level of the calcium ion inside the cell. And this will increase the contractility of the cardiomyocytes. So these drugs are working on the beta adrenergic receptors. And through activation of these receptors, this will increase the level of cyclic AMP. Then cyclic AMP will activate protein kinase, and protein kinase will phosphorylate the voltage-sensitive slow calcium channels. There is more entrance for the calcium ion inside the cells and inducing contraction. Here it is also beneficial to discuss the other class, the phosphodiesterase inhibitors. These are working on this step right here. They are, so there is a cyclic AMP is breakdown by hydrolysis, so phosphodiesterase inhibitors by phosphodiesterase. So by using an inhibitors for the phosphodiesterase, we are preventing this step, and this will increase the level of cyclic AMP. It means there is an activation for protein kinase and phosphorylation of this channel and more entrance for the calcium ion inside the cell. But mainly these agents are using for inpatients. So here we discuss the phosphodiesterase inhibitors. So, recombinant beta-type natriuretic peptides. So similar to what we said earlier, then there is when there is an activation for the renin-angiotensin-aldosterone system. On the other hand, there is an activation for the vasoactive peptides such as natriuretic peptides. And these are very beneficial in inducing vasodilatation, reducing cardiac remodeling, and also they are beneficial by reducing the harmful effect of the renin-angiotensin-aldosterone system. So these drugs have effects similar to the diuretics. They are reducing the preload due to the natriuresis effects of the drugs. Of the drugs that are that have the natriuretic effects. Then when IV diuretics, so when we are using diuretics to control symptoms in the patients, these patients still symptomatic patients, or we are reaching optimal doses, but the benefits is still not clear, or there are certain contraindications for diuretics. On those patients, it is very beneficial to use a recombinant B-type natriuretic peptide, niseretide. Here, I think this is the only drug it is now approved in this class. And this drug is binding to the natriuretic peptide receptors. It is just an agonist and causing natriuresis, diuresis, and reduce both preload and afterload. This one has around 20 minutes as half-life, so it is a short half-life, cleared mainly by renal, cleavage by when after binding the drug or this agonist to the receptors, there is an internalization for the drugs to the inside the cells, and there is a breakdown for the drugs in the inside the cells. The main adverse effects that are related to this, such as hypotension, dizziness, and like diuretics can worsening the renal function. So finally, we have an order how to use these drugs in the for patient for with heart failure. So from these figures, we have to start with the education of the patient. Then we have to control the other risk factors such as hypertension, diabetes, dyslipidemias. Then starting with the drugs such as IC inhibitors, angiotensin receptor blockers, or beta blockers. Then if the patient is still symptomatic, we have to add other classes such as vasodilators or aldosterone antagonists. Then after that, if we have still symptomatic patients, we have to use angiotensin receptor neprilysin inhibitors, or by using other drugs such as using ivabradine, drugs that are working on the heart rate. So here we have many options, but it is determined by the condition of the patients, and also is determined by the symptoms that the patient have, the severity of the heart failure. So it is similar to what we discussed in the figure. So starting with the loop diuretics just to control symptoms. Then we have IC inhibitors or angiotensin receptor blockers because they are very effective. Also, now it is recommended to start either with the angiotensin receptor blockers or angiotensin receptor enzyme inhibitors, or small doses with beta blockers. It is similar. Then it is titrated. The doses of either one of these drugs is titrated according to the patient condition. After that, we can use either aldosterone antagonist or hydralazine isodinitrate. It is similar to what we discussed in this figure, but it is depending on the condition of the patient and the symptoms, and if the patient is still symptomatic or asymptomatic. Once add optimal IC inhibitors or angiotensin receptor blockers, the patient still as symptomatic. Either we can use this combination, the angiotensin receptor neprilysin inhibitor, or also now we can go further by using drugs that are positive, that have either positive inotropic effect, or that drugs that are controlling the heart rate. Here at the end of the heart failure or drugs for heart failure. If you have any questions or comments or suggestions, please let me know by comments. Thank you very much.